Good morning.
Morning, sir.
I have some news for you guys.
Good or bad? Can you break it to us?
I don't know if it's good or bad. So yesterday I told you there was two questions I was looking at, right? The test statistically did not meet test committee criteria, right, which was a good thing. It's the first time it's happened in about 2.5 years for block one. The way we do testing, though, is that you have a previewer for the test, and generally the reviewer for the test is the same person. Well, me and my reviewer disagree about a question that I want to give back, but I think is invalid, based on my own assessment of myself and your performance and feedback you guys had. So when this occurs, it goes before test committee. So I fucked up my own thing. I was happy. I was telling people, I was like, I broke the chain. I made it so GI Block 1 does not go to test committee. And here we are, going to go to test committee. So I'm going to stand in front of my peers on your behalf, and we'll see what they say. Also hilarious, I'm the test chair. And so there's going to be knives out because I'm a fucking asshole to other people about questions and their validity. So it's going to be interesting.
Just to make a point, one extra question better.
Well, I wish I could. I wish I could just hand wave it, right? But I'm also glad that a faculty member is checking me, right? That means that faculty member put in a bit of care, because normally it's like a write-off. Like if it doesn't go to test committee, who cares, right? And so we're just disagreeing, and then we'll have it out in room 22 at 7 tomorrow. Yeah. It was the one that statistically did not perform poorly. It's the one about the EGA with biopsy, or EGD with biopsy, sorry. So, yeah, we'll play with that. There was another question after I did more. Jesus Christ, did this happen to her?
All the tests.
It's a terrible one.
So if I hold it like this, oh. But what if I just...
Take your top off.
There's no way I'm taking my top off. How would you know who I am?
That's true.
I put the aviator and I held that broom the whole fucking exam for you guys. Yeah, I did that for you. I'm proud of that. But yeah, so there was another question statistically, because we have to look at the stats of the exam. And there were 3 questions that met what we call statistical criteria, being like poor questions or questions that don't perform well. And two of them I'd already looked at, and I was like, yeah, because we had conversations and they met statistical criteria. I was like, that's convenient, great. So qualitative and quantitative coming back, right? And then there was this other one, but I was like, why did you guys get that one wrong? You're just dumb. I'm just bad at teaching it. One of the two. Like I'm keeping. I thought it was a valid question. So that one's fine. Again, it was strange. I don't know why people got that one wrong. And it was because again, when a high performer, that's how we look at it. That's how the stats work. When a top third of the class gets a question wrong, it flags it. I'm like, why did you get that? Well, I'm not going to tell you which one it was. But there was another one, right? So again, there's 3 questions that we're looking at. 2 he agreed with, and the one, the EGD biopsy. Another talking point, or the question that met statistical criteria that he agreed for PAN credit was the one about the thrombosed hemorrhoid. And do you do surgery versus band ligation? And I look back at the slide, and I didn't do a good job explaining medical therapy. So just because you have a scalpel in your hand doesn't mean you're performing surgery. So that will be a PAN credit question coming back, because it was, you guys were all over the place. Like there was no more than like 29% that selected any one answer. That's not good, right? That means I messed up, and it was clear. It was clear, and I didn't stress that point. I don't know if you've even heard those words before. If everyone's talking about like what medical therapy is versus surgical therapy. It's like anything an internist does or some specialty of internal medicine is medical therapy. And so like a GI physician, or you as a GIPA, if you do band ligation or you cut out a hemorrhoid, that's not surgery. Like surgery is done by a general surgeon, it's done by a urologist, right? It's done by otolaryngologist, like all those folks or there's anesthesia, like full anesthesia, plain of anesthesia is required, that's surgery. So yeah, that one is definitely coming back. So we'll see what happens. I've talked to other faculty and again, it's like 50-50. Hilariously too, what happens when there's a tie at test committee, because I don't vote as the test chair, but when there's a tie, the test chair votes. But when it's your exam, you don't get to vote. So it's gonna be an interesting time that we're gonna have tomorrow. And I think I can articulate well enough where I messed up. And hopefully I will pull on the ethos and pathos and of course the logos of the faculty, right? So I can fix that mistake. Now, that does lead into block 2, which that exam is nearly complete. I've got like some minor edits I'm gonna make. I've been saying like, hey, this is an easier exam. Okay, let me give you some context, right? Your guys' average time, 58 minutes. Okay. This exam that I pulled forward, when those students took it, the average time was like 56 minutes. They still had above 90% average, but so we did like what makes an exam more easy. I don't know, I feel like that's a rigorous exam in my head, even if you do score high, and I want you to score high. But there is way more first order stuff in this exam. It looks quite more sophomoric. I'll be honest with you. And remember I told you at the beginning, this class used to be a sophomore thing. And I also told you, we are not dumb to pendulum swings, right? And even though the stats looked okay yesterday, I still wasn't completely satisfied with how that exam performed. I wasn't, right? And so there's gonna be a little pendulum. It's gonna go a certain way. And if I end up going to test committee for you performing too well, I don't care, because I'm already there. I already lost my ability to break the curse, so that's fine. I'll try again next semester, if they let me teach again. I said the F word less on camera, I think. Okay, all right, so let's just some housekeeping stuff. Questions?
Can you repeat the question?
So we've thought about it. We've gone back and forth about letting a student come in.
That would be good.
And we've decided absolutely not. Absolutely. And a lot of it has to do with me. Not that I'm unprofessional, even though I am, but there's some back and forth, and especially for a newer faculty, here's the trend, right? You teach something for the first time, it goes to test committee. That's just the norm, right? I'm the exception, routinely. Like with HNT, for you guys that didn't go to test committee, you did just fine. But it's just the norm. It's absolutely normal because you're not as a master of the content as you would want to be. And your first look through the test itself and the questioning, you think, oh, okay, this is fair. But then after you deliver it, well, like, I don't know. Maybe this isn't good. It's already been previewed. It's already, like, you already put that bullet into the magazine. Like, it's ready to go. So there's a steep learning curve there for sure. So next semester, 25-1, we'll have a better product for GI than you. Know that everything that I'm delivering up here, right, is still this much of what exists in current for GI. And not just current 2025, the gastroenterology current as well, which I'm only like just a little bit peeking into for you guys, because some of that stuff is just not primary care, and I cannot, like, and you're gonna see me flash forward through some stuff where I had to go into the gastro, because it wasn't in, to like the modern 2025 current, it was not in there. Okay, that was a rant, sorry. I answered your question, I answered my own question. I had a whole moment, it was great, okay. So let's talk inflammatory bowel disease. I'm gonna try and do this with this. So you say tuck it in behind. All right. Okay, so inflammatory bowel disease. 3 topics. Honestly though, it's only 2. Okay, and you're gonna see when we get to microscopic colitis, I'm going to speed through it. Because again, current, when it gives us its chapter about inflammatory bowel disease, doesn't even mention it. Okay. It's not on your pants. It's gonna be a nice note. Makes a great distractor for a question, I guess, but that's really about it. So what is it? Inflammatory bowel disease is 2 conditions characterized by chronic recurrent inflammation of the GI tract. And we're gonna hit these pretty hard. Know that the majority of this lecture is high test fodder. Meaning there's going to be several ways for me to show you differences as to whether or not the patient has Crohn's versus ulcerative colitis. And some of it will even be in basic history and physical. And I will point that out to you. Sometimes I even italicize it so that you remember it. Like those are the things that you should remember when you're trying to differentiate these 2 disease processes. So Crohn's, any segment of the GI tract. Ulcerative colitis always involves the rectum and extends proximally. And you're gonna remember, I'm gonna be using a lot of anatomic terms today. Proximal, distal. As we get closer to the ileocecal valve, we're getting proximal. As we get closer to the anus, that's distal, okay? So don't mess that up. I'm gonna use those words like in vignettes, okay? So just graphically, a way to look at it. This is a nice image, like once we're done, for you to look back and go like, okay, so really where is Crohn's, where is ulcerative colitis? But I'll point out a few things for you here. So you can see with Crohn's, you've got ascending colon, all in red. So think, if that's where it's impacting, if that's where we see the disease manifest itself, then clinically, this patient likely has right lower quadrant pain, right upper quadrant pain. Now, compare that to ulcerative colitis. Where's most of the red? It's at the splenic curvature, the splenic flexure, right? Down into the sigmoid colon. That's all left lower quadrant, left upper quadrant. Thankfully, most patients present with that sort of manifestation right off the bat, okay, which is nice. The other thing you'll see with Crohn's though, again, it's the entire GI tract, entire alimentary canal, from mouth to anus. So this is just a chart from current, from up to date. This is not something for you to memorize. This is a nice to know here. When we get into the extraintestinal manifestations, I will point those out to you. And we'll go over a few of them that are just kind of classic presentations or schema for these different disease states. But there's some interesting stuff in here. The things that, when they present to you, you're probably gonna build a pretty robust differential. Like someone just has arthritis, right? Are there other disease states, maybe lupus, rheumatoid arthritis, right, that might look like this? Uveitis, arthralgias, interesting things there. And again, I will point out some more common presentations. All right, so let's talk Crohn's. Inflammatory bowel disease characterized by transmural inflammation. And hopefully you've heard that word before, likely in cardiology, like a transmural infarct. Right, that just means it goes from the edge all the way to the end of the tissue. So it's full scoping. there. It may involve the entire GI tract as well, not the anus. Common presentation in the terminal ileum. And where is that terminal ileum? That's right lower quadrant, okay? It can lead to ulcerization, stricturing, fistulization, which we'll talk quite a bit about, and abscess formation. And these extraintestinal manifestations are common, and I'll point those out to you. It ranges from mild to severe fulminant disease. And here is yet another distinguisher between Crohn's and ulcerative colitis. Worse in smokers. And we'll touch on that as we get into UC later. Another characteristic of Crohn's are these things called skip lesions. Now you won't see that word much in the literature at all. But what it means is that when we do endoscopy, we're able to see normal, healthy bits of tissue and then gross ulcerated tissue. This is yet another factor that differentiates Crohn's from ulcerative colitis. Because in ulcerative colitis, it's uniform. The whole sigmoid, right, is infected. Not infected, but inflamed. Highly variable clinical presentation. These patients have exacerbations and remissions. That's no different than ulcerative colitis. They generally present with fatigue, prolonged, usually non-bloody diarrhea, yet again, another differential for ulcerative colitis, but then weight loss, fever. If someone just presented just like that, right, again, depending on their age, I'd be thinking a whole lot of stuff, right? Systemic, generalized symptoms, that's all bad news. So commonly, it's attacking the terminal ileum. These patients have right lower quadrant pain or right upper quadrant pain. They've got malaise, weight loss, fatigue, non-bloody intermittent diarrhea. We can also see intestinal obstruction due to constant inflammation. That's where they get stricturing and narrowing of the bowel lumen. These patients will then say, hey, after I eat, then I just get really bloated, or I'll get this cramping abdominal pain that will occur. And then I can hear my bowels constantly, like loud enough to where you don't need a stethoscope. And you guys will encounter that a few times. You'll walk into an exam where you'll pull back the curtain and you'll just hear the tummy talking. Okay, you know there's some goodness going on. This is a penetrating disease. The penetration part of Crohn's is yet another factor that makes it different compared to ulcerative colitis. And why is that? Because this is a transmural disease process. It can go all the way through tissue and create these little sinus tracts. That penetration and inflammation is called a phlegma. That's not an infection. It's not an abscess. This is just generalized pain, maybe indurated. You might even palpate it on exam, depending on where it is. These patients are not presenting with a phlegmon like they have an acute abdomen. You're not thinking, I need to get them to surgery. It's like, oh, it kind of hurts right here when you press on it, sort of a thing. Their heart rate's fine, blood pressure's fine, no fever. Contrasting that is the abscess. I think about a deep abdominal abscess, now we're getting more systemic symptoms. This is a cervical abdomen, pain out of proportion. They're febrile, they're tachycardic. You may even see peritonitis in these patients. All right, let's talk about these fistulas. These are those tracts, commonly aligned or organs that are right next to each other. And I kind of mentioned this a bit yesterday. You've got some chronically inflamed tissue. And again, this is transmural. And in the abdominal cavity, the bowel sits on top of a whole lot of other things. If it's sitting on top of the bladder, that inflamed tissue can allow for transference. If it's sitting on top of the uterus, uterine tubes, if it's up against the abdominal wall, even in enterovaginal as well. And what do those look like? So those enterovesical fistulae, so say that there's small bowel, again, resting on inflamed large bowel, we probably won't see a whole lot. Probably clinically, we're not going to see a whole lot of difference there. However, if that inflamed bowel is up right next to the abdominal wall, and now there is feces coming out of their freaking abs, well, okay, that's different, right? That's a strange thing that's occurring. The vesicular ones as well, the UTIs, so I think where the ureters come down, touching bowel, now we get ureter inflammation. You now get bowel transference of feces, right, stool, into ureter, and also air. And so now you may be going number one, and it sounds like it's a Coke machine. It's like spurting, right? You're like, what's happening here? That's a weird thing for you to notice. When you pee and there's farts coming out of your pee hole. Strange, right? That would be strange. Okay, good. Yeah, it is strange. You can laugh at that. That's a weird thing. Maybe it wasn't a good analogy, but I'll work on that. Then you can see fistulas of the retroperitoneum that can lead to psoas abscesses, right? Obstruction, it can lead to hydronephrosis. It can get really bad quickly in these patients with Crohn's. Perianal disease, also another common finding in Crohn's. The large, painful skin tags, and then hey, this is a block 1 thing, now becoming a block 2 thing. Anal fissures. And where are they? Lateral. If they're at the 3, right, or the 9, we're thinking that possibly this is inflammatory bowel disease. If it's at the 12 and the 6, we're okay. You can get perianal abscesses, also additional fistulas, sinus tracts as well. Now let's talk about some extra intestinal manifestations. This is where, again, we're seeing systemic effects. And think again, these are systemic disease processes. Arthralgias, arthritis. Non-deforming though. When you guys get into senior semester and you're learning about lupus, I know you've already spoken a bit about it, you've spoken about rheumatoid arthritis, psoriatic arthritis. Those are changing joint lines, right? That's a common effect that's happening there. With Crohn's, there's no degeneration, it's just they hurt. Right? They hurt in those places. Iritis, uveitis, again, thinking autoimmune, right? The cutaneous manifestations, pyoderma granulosum, I'll show you a picture of that. Erythema nodosum as well. These oral aphthous ulcers, those painful ones. This is worse than like a cold sore there. It's like, ow, it hurts there. We also see an increased prevalence in gallstones. So talk about a complicated patient presentation. Like, wow, you're having a Crohn's exacerbation, and oh, by the way, you've got choledocholithiasis. That's frustrating, right? There's that pyoderma granulosum, erythema nodosum. I'm not going to describe these manifestations in proper dermatologic ways, right? You're going to get those, just as they are. Lab testing. Nothing truly specific here. We're getting CBC. Why? We're looking for anemia. We're looking for leukocytosis because could this cause a lower GI bleed, or upper GI? It could, right? CMP, we'll get into liver stuff a bit more specifically tomorrow, and we'll talk about that. Then the iron and B12 levels. And why B12? Well, this has an entire manifestation across the entire GI tract. So they could have nutrition deficiencies all over the place. This is where maybe that vitamin B1, vitamin B2, vitamin B12 would become relevant to you in this Crohn's patient. Because if the intraluminary cannot absorb the vitamins where it's supposed to, and a lot of that stuff was terminal ileum, they'll be deficient. Albumin levels, again, looking at their nutrition status. They're not absorbing the proper nutrients. ESR-CRP, looking for inflammation. Can be a marker on the course of their exacerbation. Fecal calprotectin. Have you guys heard of that one before? No, okay, I didn't think so. I wasn't certain though. So you can think of that as the CRP of the poop. It's very sensitive to inflammation within the bowel. So if I tell you that the fecal calprotectin is elevated in a patient, you'll know that there's inflammation. It's an inflammatory process. And for pants stuff, that will also come into play because you're going to get a vignette and you're not going to know what is the differential. And you may have to differentiate Crohn's versus IBS-D, right? There's not going to be an increased fecal calprotectin in IBS-D. It will be in Crohn's though. And then stool culture of O&P, yeah.
So you've got the calprotectin there. What about the lactose there? That does a similar thing, right?
It does, yes.
So what's the advantage of using the calprotectin?
More sensitive by quite a bit. By quite a bit. It's a good question. Then stool cultures and then O&Ps. And we're doing those things as rule outs, right? You'll see when we get to ulcerative colitis, there's going to be a few other ones. That'll make sense to you, trust me. How do we establish a diagnosis though? If I told you that I can't just do a lab, right? Then I've got to go in and take tissue. I got to put a camera in there, I got to go grab it and get histology/pathology. That's the workup. And we do that with colonoscopy first. Okay, and we're getting all the way to the terminal ileum. Again, another difference to ulcerative colitis, because we were saying earlier, I showed you the colored pictures. I could probably just use a flex sig if I was thinking ulcerative colitis, right? So I don't need to go all the way to people who just tell me to do the whole colonoscopy. Yes, but you could, right? You could absolutely just stick with the sigmoid. If they do have upper GI symptoms, and that could be any of the things we talked about in the last blog, it's like GERD, that kind of stuff, right? And we're doing upper GI as well. Capsule endoscopy, we'll hit this up in the next lecture when we get into cancer screening. That's as indicated. And we'll talk about when that might be indicated versus when it's not. And then CT and MR enterography, we're just looking at the small bowel, because that is a difficult thing to assess in a way, but again, modern technology, enough contrast with enough CT slices, and our CT slices are pretty darn good. I mean, I showed you those reconstructions. We can get a good sense if that small bowel is inflamed or not, if it's apart. And why would that matter? For treatment. Do I need to do systemic things for you or not? Or can I just use topical? And know that when we're talking inflammatory bowel disease, topical means through the butt. Okay, that's an enema. That's what topical means. All right, there is a determination of severity scale. This is a nice to know. I'm not going to spend a whole lot of time on this, but there is an entire, you can just tick the boxes off and determine how bad things are, or you can just be a clinician and make it fine. All right. Risk stratification though, where one to look is, are these patients, are they low? Are they moderate? Are they high risk? How's their inflammatory status looking? And how do we assess that? Through endoscopy. And principally, take some tissue. We look at C-reactive protein or fecal calprotectin. Are there upper GI issues going on as well? So treating the various things, and hope some of this stuff will be intuitive, right? If they have an abscess, an obstruction, a fistulization, they need to see a surgeon for that stuff. Clearly, you can have GI on board, you can have medicine on board, the hospital's on board, but if it's that severe, they need surgery. Most of our treatment is directed at symptom control and then trying to get them into remission. And then talking to them about stuff that they should not do, right? No smoking. Because we know that smoking, specifically smoking, exacerbates their symptoms. No cure. This is an expectation management thing. And as you'll see in a few minutes, we can talk a bit more about expectation management. You get diagnosed with Crohn's before you're about 30 years old, the chances of you having surgery in your lifetime because of your Crohn's is about 50%. It's a hard conversation to have, but also you're on your P's and Q's with regards to how are they doing, right? Your goals of therapy: induction, achievement of remission, and then maintenance, the prevention of recurrence, complications, progression. And I mentioned that we've got symptomatic medications. We've got medications for active disease, meaning that their inflammatory markers are off the charts. And then we have medications for maintenance therapy to kind of keep them in remission. So what are those symptomatic meds? Easy. Loperamide, right? Help with the diarrhea. Absolutely. Bile acid sequestrants as well. Especially if there's a lot of involvement in the terminal ileum. Because again, we're thinking about the mucosa there. If it's not able to absorb those bile acids, that's just going to be straight diarrhea. Okay. Oral steroids for the Biatus ulcers, anything up here in the mouth. You can see it's Kenalog and an Aura base, triamcinolone oral prep as well. But here's our low risk folks, all right? So no symptoms or mild symptoms. They've got normal or minimal elevation in CRP or fecal calprotectin levels. They're over the age of 30 when they're diagnosed. Limited distribution of bowel involvement. The ulcers are superficial, no perianal complications, no penetrating stuff. This just makes sense, right? So what do we do? If they've got, and we'll talk mild Crohn's disease, how do we induce it? Steroids. So we'll use budesonide, and we'll get 50 to 70% of induction there. Or you can use prednisone or prednisolone. Now know when it comes to steroid giving to patients, remember where there's high potency, low potency, medium potency, and that same stuff applies oral. So generally we want to stick with budesonide, right? If they are not responding to budesonide and they have mild symptoms, then we can go on to prednisone. And there's going to be more systemic effects. There's also these other meds, these 5 ASAs or aminosalicylates. Have you seen that word before? Salicylate? Salicylic acid. Which is what? It's aspirin. See, these are aspirin derivatives. That's crazy, right? Well, to me it's crazy. We've got sulfasalazine, mesalamine, and we'll talk a bit about the nuances of prescribing those more, and ulcerative colitis. Those are a mainstay of ulcerative colitis treatment and not of Crohn's. Again, another difference. So we've got diffuse colitis, left-sided involvement. These folks are getting the higher steroid. They're getting prednisone, they're getting prednisolone. They're also going to get sulfasalazine. Again, it's less effective though in inducing remission in these patients. So in those patients that we get to remission, meaning that they're generally symptom-free, we don't only got to keep them on any meds. We monitor them, right? We're doing scopes kind of routinely, and we'll talk a bit about that as well. We'll look at C-reactive protein levels, fecal calprotectin. You're going to get an endoscopy every 1 to 2 years. Okay? If it required us to go from steroid 2 of 5 ASA to get them into remission, we're going to do a C-scope in about a year, if not sooner. Let's figure out what's going on. And they may be on some sort of medication for a long time. Likely the 5-ASA and not the steroid. Why? Cushing, right? That's why. Like, that's it. We don't like to keep patients on systemic steroids for maintenance. We don't, because of Cushing. All right, now let's talk high-risk folks. Less than 30 getting diagnosed. I'm talking 18-year-olds, right? This is a thing. This isn't like the made-up stuff, folks. But this is real here. They're smokers, or they've got some type of nicotine addiction, higher risk. Elevated levels of our inflammatory markers. Deep ulcers on colonoscopy. We have really long segments of the small or large bowel. Then we get the perianal disease, the visualizations. They've already had a bowel resection. That's a high-risk Crohn's disease patient. So these patients are going to get a completely different treatment regimen compared to those mild folks. So they're getting budesonide if they have isolated ileitis or prednisone as a bridge. And you will see this in rheumatologic disorders routinely. We hit them with steroids quickly because those have near immediate action. And at the same time, we put on one of these biologic agents, and an immunomodulator, because it can take 6 to 8 weeks for those to reach peak efficacy. Just like a PPI, it takes 4 to 6 weeks for you to actually get a result. Same thing with other meds. They have to be on board at a therapeutic level for a longer time. So that's what we bridge with those moderate, medium potency steroids. Now you'll see, I've got a lot of meds here, the biologic agents, immunomodulators. Those are nice to know. This is not a farm class for you. You will be able to prescribe those, but you can't. You shouldn't. Unless you guys are in a GI clinic where you should not be doing it. But you'll see, like infliximab, I will put that onto an exam question as a distractor, and then you just know it's going to be wrong if you're choosing that. Okay. All right, so we've still got. Okay. They can, so we put them into remission. Yeah, that is and defining remission is even more nuanced. So is it okay if you use loperamide 4 times a week? Sure, if you're not on a immunomodulator, you're not on steroids, you're not doing topicals oral, sure, you're in remission. Okay. So they've got clinical findings, right? Endoscopic, histologic, we're good. We think that they are in remission based on our whatever criteria we provide. They're going to be on that anti-TNF for 1 to 2 years. There are some serious side effects that come with those meds. There's some serious knowledge gaps that you're going to have to fill. What kind of vaccines can they receive? So, like, yeah, this is where it steps up a little bit, your cognitive ability to talk to the patient about what that actually means. So for us right now, it's just a simple data point, but in real life, like, that has consequences. Okay. The other thing that's nice, if a patient loses a response, so say they have like a flare, when we think we're trying to be in remission, we think that anti-TNF med isn't working anymore, we can just switch to a different one. And maybe that one will work. The mechanism of action for these anti-TNFs are so different that that's allowed, even without a prior authorization, which is nice. There's either going to be a vanity resistance if you get into private medicine, being able to switch in between classes. right? And did you do all the steps in order to provide the patient the treatment you think they deserve and need? Surgical indications. Like, hey, we did the steroids, we did the immunomodulators, the anti-TNF. They're still having issues. We're taking up part of the bowel. Sorry. We just need to get it out. They have a legit obstruction. Taking it out, we're seeing gym surge. Any abscess formation or any type of fistula, again, they need to see surgery. Who do we admit? Well, obviously, surgical patients, as I just mentioned there. Serious infections, someone that's on an anti-TNF that gets just a normal skin infection, that can become sepsis or SIRS quickly. They've got severe symptoms of diarrhea, dehydration, weight loss, abdominal pain. And how would I describe severe? They're hypotensive, they're tachycardic, they're febrile, not 100.6, folks. Right? This is 101, 102, right? In adults, that's not normal. That's severe. Who are we consulting? GI, clearly. They're on board. You're in a GI class. Nutritionists, of course, as well. There is a Crohn's and Colitis Foundation of America that can provide a lot of treatment options for you as well. Like, this exists for a lot of weird things, right? Like cystic fibrosis. These foundations will help you clinically, which is really nice. You're like, hey, this is what we're doing now. Here's how to fill out prior authorization. Here, make this happen. They do that stuff. It's really nice. And then surgery is necessary. Questions on Crohn's? You guys know who that is? Familiar to you?
Dr. Crumb?
Oh, this is Walt Disney. Who had Crohn's. Yeah, it inspired Steamboat Willie. I'm kidding, it's freaking Dr. Crone. Of course it is. Oh my goodness. That landed about as good as I thought it would. Kind of does look like Walt Disney. You can see his wife in the background. It's really nice. Okay. All right, switching gears. A white flag? What? What is the white flag?
Break.
Oh, you need a break. Okay, that's fine. So we're at 32 minutes. So yeah, let's take 10. I'm fine with that. Take 10.
Oh, we didn't start. I thought we started directly after. My bad.
Keep going.
Keep going?
You're good.
All right, I'll bring it back. If you got to pee, go pee. Here's what I'll do. We'll get through ulcerative colitis because it's about 30 slides. I think it'll go a bit faster because I'm going to highlight the differences. And there are a few. There's enough to where these two disease states should exist differently in your brain. Yeah.
A real quick question first. So moderate to severe, you said just knowing the meds is kind of FYI for like the 6 months, but they're going to be taking the corticosteroid for the bridge, and they will be taking the TNF plus the immunomodulator.
Correct. Yeah, so again, a difference. So, and this is how I might distinguish it. Right? I'll give you a moderate or severe looking patient, and there's going to be 3 answer choices in a row for each distractor. It's like steroids, anti-TNF, immunomodulator, oral steroids only, topical steroids, 5-ASA, right? Like that's how I would test you on that. Yeah, and I will, here's the other thing too, like when it's relevant for you to know the class of a medication, I'll tell you. If I'm speaking to you about differences in common medications, specifically steroids, you need to know that going forward. I'm telling you, you just have to know that like prednisone is different than triamcinolone, which is different than clobetasol, which is like, that is stuff that you have to get into your brain, right? And those are like common ones that will have clinical outcomes that will differ Okay? Hydrocortisone 2% versus 1%, where do you put them? That kind of stuff. Like that, those things matter. It's not just like fluff info. Those are things I use on a regular basis. And then you're gonna get tested on derm. Okay? It's gonna be straight up there. But like, yeah, so another budesonide being kind of lower. I was like, hey, lower is good. But if the lower doesn't work, go to a medium or moderate. And the medium or moderate is prednisone, you need to know that. All right. Idiopathic inflammatory condition limited to mucosal layer. Crohn's, transmural. This is just the mucosal layer. This is another nice thing that I like about ulcerative colitis. A quarter of patients is confined to the rectus sigmoid region, and then half extend to the splenic flexure. So what that tells me, and should tell you, is that 75% of your patients that have ulcerative colitis are gonna have left lower quadrant pain, which is nice. You can't get it more proximally, that just means it's extensive, and that's what it looks like. Okay, so everybody with UC has got proctitis. Most everyone's got proctosigmoiditis. You see the distal colitis there. Extensive versus pancolitis. So things get really bad. Also, though, this looks like Crohn. They're going to have exacerbations. They're going to have remission. It's waxing and waning. And it can range from mild colitis to fulminant colitis. And with fulminant ulcerative colitis, that's when the toxic megacolon comes in, right? This is the associated pathology. We had C. diff that could cause it. Now we got ulcerative colitis that can cause it. The extraintestinal manifestations are similar to Crohn's, with another key difference. Fistulations, not as common. So if you see a vignette and there's discussion about fistulations, know that it's not UC. It's Crohn's, right? This is weird. And I went down a rabbit hole with this one. The disease severity is lower in active smokers. And they actually worsen in patients that quit. That's a strange conversation to have. I don't want you to stop smoking because it's going to help your UC. Right? That's a weird thing. They've got several different theories as to why, but they don't know still. And it's a strong enough correlation that it's in the literature, folks. Like this isn't like a one-off thing. I just think it's super interesting. And then having that, would you rather get lung cancer, cardiovascular disease, or do you want to not poop blood? I go with the not pooping blood part myself, but you got to have that conversation. So, continuous erythema and ulceration of the mucosal surfaces there. And here's typically how it presents. It's just a nice chart. You don't need to memorize everything on this chart. And some of this should be intuitive for you. Like, am I gonna make you distinguish between mild and moderate? No, pay attention more to mild versus severe disease. You're having 6 mostly bloody stools in a day. That's severe, okay? You can see their pulses, and we hit pulse yesterday as well. So again, if they're tachycardic, not doing well. If they're anemic, not doing well. Another way to differentiate this is look at mild to moderate, gradual onset with blood. With Crohn's, we did not talk about blood a lot. It's not a normal staple of Crohn's, but it is of ulcerative colitis. Fecal urgency, tenesmus. That's that uncomfortable feeling like I need to poop, but there's no poop in there. Left lower quadrant pain. And pay attention to this. relieved by defecation. Does that sound familiar from block 1? Now, I can't test you on that stuff from block 1, I won't. But I will put it as a distractor, okay? I will make it so that IBSD, right, is a distractor for you. One of you will pick it, I'll laugh. I'll giggle. But for the pants, though, that's a way that they're going to mess with you, okay? There should not be blood. There should not be, full-on inflammation of the sigmoid colon in a patient with IBSD. But there will be ulcerative colitis, okay? With the severe, I already mentioned the greater than 6, hypovolemia, anemia, they're down on protein, they're malnutritioned, left lower quadrant pain, all those things. Bowel movements are frequent, small in volume. But why does that matter? Small in volume. Well, I told you yesterday, if someone has diverticulosis and they have a bleed, they'll squirt it into the toilet, right? Here it's just like, oh, I don't know what happened. There's a little bit in there. There's a little bit of blood. I had pain and a little bit of blood. Versus the toilet bowl looks like Jaws. That's a weird thing to say too. Okay. What are we testing? CBC, again, looking for anemia. CMP we'll talk more about. Albumin, because we're looking at nutritional status. CRP and ESR as ways to gauge inflammation. Fecal calprotectin for the same reason. Stool cultures, O&P, but here is where things get different. Testing for STIs. These same symptoms can look like an infection of the sigmoid of the rectum for HIV, syphilis, chlamydia, gonorrhea. Now, sexual history might become important to your interview. Otherwise, it might not be. Hey, maybe we should test you for those things. Yet again, endoscopy is establishing the diagnosis. Okay, we're getting tissue. And if it's an acute disease, right, flex sig, we're avoiding full colonoscopy because of the perforation risk. We can incite toxic megacolon. And I mentioned this again before, right? If most of the disease is within the sigmoid, then that's all I really need to look at. Whereas with Crohn's, we're thinking it's full-on GI tract. I need a colonoscopy to go and hit that splenic flexure, hit the hepatic flexure, go down and look at that ileocecal valve. And this is what we see on biopsy. Ulcerative colitis is crypt abscesses, crypt branching, shortening, disarray, crypt atrophy. So similar treatment approach to Crohn's. We're treating the acute, the active disease, we're trying to prevent recurrence to maintain remission. As we'll talk about as well, the severity of the disease is clearly going to impact how we treat. And a main difference between UC and Crohn's is that we're starting with 5-ASA. And those are the mainstays of treatment. And you're going to need to know that, smile me, I'll show you the names again. The 5-ASA has 2 words that are associated with it. This is just an excerpt of the American Gastroenterology Association ulcerative colitis. This is from their clinical practice guidelines. And it's just telling you, hey, if you have a whole lot of inflammation extending past the sigmoid, then topical meds might not work. You're probably going to have to do some type of systemic medication to help that patient out. That's all this is saying. So, mild, moderate distal colitis is confined to the rectosigmoid colon. Mesalamine, which is a 5-ASA drug, so that's a name you'll need to know for this exam. That's our drug of choice. And it's administered topically as a suppository or as an enema. Other things we can do, topical corticosteroids. And now, if a patient's unwilling or unable to use a topical therapy, then we can use the oral form of the 5-ASAs. That could be mesalamine or sulfasalazine. We'll talk in a second about why you might choose one over the other. And why might someone be unable to use topical therapy? Like the bill, right? They're like, maybe they've got serious arthritis of their shoulder, okay? They can't reach back there and do that. So we have to think about those things as well. Or they're just unwilling. They're like, I'm not doing that, doc. You're like, but it's the best. And they're like, no, it's not. And you're like, okay, well, we'll try this other stuff. Refractory distal colitis. These folks are going to get co-therapy. So they're going to get an oral and a topical 5-ASA. And we're certainly going to add glucocorticoids on board as topicals. And potentially add oral prednisone for these folks. Now we've got mild, moderate, extensive colitis. Right off the bat, and this is kind of similar to refractory, kind of being a bridge into this is mild or moderate, extensive. We're doing oral and topical 5-ASA, so mesalamine, sulfasalazine. Sulfasalazine, higher side effect profile, but it's cheaper. Socioeconomic terms of health, things you have to consider. It also requires co-administration of folic acid, the way that it works. Think about like how drugs like methotrexate work and their delivery. So we have to offset with folic acid supplementation. These patients are also getting topical corticosteroids, and that's added if there's no improvement in 2 to 4 weeks. So again, another big difference, looking at extensive colitis, it's oral and topical 5-ASAs right off the bat. So patients that respond to topical mesalamine or 5-ASA, continue nightly therapy. If they require the oral as well, continue therapy. Now, why do you think we give that topical at night? Movement, gravity. I don't want it to fall out. Okay, I want it to stay in there. Okay. Think about your patients, like this is happening to them, and you're thinking about like they're gonna go to sleep. Like what if the mesalamine gets all over the covers? Like, does it bleach out? I don't know. Okay. Moderate extensive colitis. These folks are getting oral steroids, that makes sense. Immunomodulators, anti-TNF agents. There's other biologic agents you can take as well. If it's severe, if it's fulminant colitis, this is inpatient. They need to see gen surge sooner rather than later. Because again, if it's not responding to our steroids, we're taking out the colon. We're taking out that part. Okay. If we're making them NPO, why? Because we're going to take them to surgery, likely, right? And also we know that's going to exacerbate their symptoms, so we might put them on, it's called parenteral, right, nutrition, so just through the IV. And we're giving them IV steroids. We don't want to take these folks to surgery. We don't want to. If we have to, we will. Absolute surgical indications, they've got some type of severe hemorrhage, a perforation, carcinoma of some sort, that's intuitive. Relative, it's severe, like we've mentioned, and refractory to everything that we're doing, they're gonna get surgery. What are you gonna call? GI, okay, and gen surge. And there are, like within gen surgery, so not only do they do 4 years of medical school, 5 years of a general surgery residency, they will then do, on top of that, 2 to 3 years of a proctology residence, just specializing on that type of surgery. Okay, these are highly specialized physicians. Who do we admit? This is all clear, right? These are all intuitive things. People that are unstable, people that look bad. They're used to trusting your gestalt. You're going through, feeling your stomach, this person is sick, they need to be admitted. They gotta get other people on board. And what do they look like? Abdominal pain, it's worsening. You can see a progression, distension, high fevers, tachycardia. They just look bad, they're going off the cliff. Questions about UC? All right, last thing for this lecture. It's microscopic colitis. So I mentioned at the beginning, inflammatory bowel disease is Crohn's and UC. And we diagnose it via endoscopy, which is colonoscopy, right? We're taking tissue, looking at it. Here, we were thinking it was one of those two things. We took the tissue, it was normal. Okay. More common in women aged 60 to 70. That's strange. Okay. If someone's coming to you with GI, lower GI complaints at that age, you should be thinking cancer, right? We'll talk about that next. They don't know what causes it. This looks a bit more like Crohn's. It's non-bloody diarrhea, but they can still get all those other things. Right? 4 to 9 watery stools a day is a lot. So we're ruling out Crohn's versus ruling out ulcerative colitis with endoscopy. That's really the main thing we're doing. We're still going to do the stool O&P. We're still going to do the STI checks. We do all those things. And if we can associate a medication or something to these symptoms, we try and discontinue it. If that's not working, try loperamide. If that's not working, try a steroid. Okay, so when it comes to surveillance of cancer, we're going to hit cancer again in a minute. I'll try to send you guys on a break. But constant inflammation is associated with malignancy. Right? If you're constantly inflamed, you arrive at dysplastic tissues. We don't want that. So these folks are going to get regular screening. You can see they're 8 to 10 years after disease diagnosis. And I mentioned before, in a severe disease patient, it could be 18 or 19. So at 26, 7, 28, they're getting their first colon. It probably wouldn't be their first, right? They would have had several to get the diagnosis. But they're getting one specific for cancer. And then again, the nuances of the colorectal cancer screening I'll hit on more in the next lecture, but just know that there is an association with these two disease processes, these two inflammatory processes, and colon cancer. And it must be screened separately to just managing and looking at their remittance. Like, are they in remission or not? All right, now take 10 minutes. Our most common edematous polyps. These do have malignant potential, and they are dysplastic by definition. Remember, dys was bad. This is bad. If they're less than 5 millimeters, though, kind of what else, right? Our positive predictive value versus negative predictive value can be adjusted based on size. So again, think back into the person performing the colonoscopy. They see this thing, it's tiny. They're remembering, okay, cool, I remember what that was. It was tiny. I don't think this is cancer. I'm still taking it. And it goes to the pathologist, knowing that, hey, this thing was tiny, looks at it, nope, dysplastic, not cancerous. I was expecting it to be negative. It all matches up. Cool. Now, if it comes back positive, one, maybe it was mislabeled. Maybe you don't trust the report. Regardless, we gotta go back in there, right? Serrated polyps display a lumen with serrated or stellate architecture, and these also include the plastic polyps. Hyperplastic versus dysplastic. Mucosal, no clinical significance, who cares? Right? And then the submucosal lesions just that have a polypoid appearance overlying the mucosa there. So what's bad to see? This is what matters. And know that in your pathology reports, it might not say the buzzwords that you want. They may just use this clear language when talking about it. So you see something like adenoma, or adenomatous, dysplasia, dysplastic. That's not good. That's bad. Is it terrible news? No. It just means we got more to do. If it says hyperplastic, hyperplasia, I don't really care about that. Whatever. Okay? But again, we said that generally, like, the bowel does this. It either grows out or grows in, either or. So a few syndromes, we're going to storm through these. I did a deep dive into these things and saw the epidemiological data is just not great for these things. So I'll mention them to you here. I'll show you them here. This is nice to know. This is nice to know. Might it be a distractor somewhere? Sure. Okay. But I don't really care. You walk away from GI not knowing about this polyposis, Putz-Jaeger's syndrome, right? Or Lynch syndrome. This is 3 of like 400 different named syndromes where people are at increased risk of polyp forming, which means that they're at increased risk of cancer. Okay, cool. Okay, someone's got some weird disease and they got a polyp, I wonder if that's cancer, okay? That's really all you need to take away from that. More importantly, we need to know that cancer is associated with Crohn's and ulcerative colitis, inflammatory bowel disease, right? That's not a polyp. But it's cool. You guys know that movie? Yeah, it's not Spaceballs, that's the real one. Okay, switching gears, more important. Now we're getting into cancer screening, colorectal cancer screening. It's the second most common cause of cancer death in this country. So we need to know about this guy, or gal, I don't want to engender colon cancer. Age-wise, 90% occur in individuals greater than 50 years old. You'll see that our screening criteria have something to do with that. Personal history of polyps, especially if there's multiple, they're bigger than a centimeter, there's dysplasia, they have a personal history of cancer, intuitive, okay? Personal history of IBD. We've got a family history of colon cancer, especially young folks getting colon cancer. Multiple first-degree relatives. What is a first-degree relative? Is that your stepson? No. Is it your stepdad? No. Is it your aunt or uncle? No. Is it your grandfather or grandmother? No. Right? It's your brother or sister. It's your mom and dad. Right? I think, again, genetic tree there. So if there's no genetic data from the people that are called those things and you that are shared, then you don't have a family history of colon cancer. Ethnicity, again, this goes back to socioeconomic terms of health. And do we see it more often in minorities, African Americans? Yes. Do we know why? No. A guess, though, is access to care. That is one guess. Then lifestyle, smoking, sure. Obesity, that is a risk factor for cancer, folks. Obesity is. Sedentary lifestyle, diabetes, the high fat versus low fat diet's not really a thing. That's the poop tube, there it is. Anybody skateboard? No, it's okay. How do they present? Most are asymptomatic. However, if you see someone who has microcytic iron deficiency anemia, and men of any age, and postmenopausal women, it's colorectal cancer until proven otherwise. That's where you should be thinking. What can they have? Abdominal pain, cramping, change in bowel habits, rectal bleeding. They get the generalized symptoms, the fatigue, the weight loss. There's some directionality, location-based symptoms that exist here too. So right-sided colon, iron deficiency and anemia is more pronounced, the weakness and fatigue a bit more pronounced. Left-sided colon, more changes in the bowel habits. Hopefully that makes a bit of sense to you. That's where the poop is actually formed from the left side. You can see stool now streaked with blood, the obstructive symptoms. And if it's in the rectum, you get full-on hematochezia. The tenesmus, like, hey, I feel like I need to go to the bathroom. And then they could go and nothing comes out. Why? Because there's a big polyp that is cancerous within the rectal vault. You can also see this thing that's in the literature called ribbon stool, pencil-thin stools, and I'll show you some examples of why that was a thing. I've spoken to many surgeons about this, and they just completely disbelieve it. They don't believe it, but I'll show you. Talk about it. So signs of advanced or metastatic disease, complete obstruction, an apple core lesion. I'll show you some pictures, and that will kind of lead us into those ribbon stools or pencil-thin stools. If they already have weight loss or other generalized symptoms, that's bad. Typically unremarkable physical exam, can see signs of anemia, you can see weight loss, you might be able to palpate a mass. You must get a DRE on these patients. Lab-wise, it's all non-specific. CBC, why? Because I'm looking for how's the red blood cells doing? Is there an inflammatory process occurring? CMP, as we'll mention about nutrition and stuff. Iron panels, because we're looking for iron deficiency anemia. Right off the bat. Right? Whereas before, if they didn't have fatigue, I probably wouldn't order that iron deficiency anemia panel. Colonoscopy, though, study of choice. So here's that apple core lesion. So what happened here is that a barium enema was utilized to observe the bowel. So you can think right off the bat, this is an older radiograph. So we'll use colonoscopy now, use sigmoidoscopy now. But you can see the contrast thins there. It narrows. And so the idea was, if you've got a whole bunch of stool proximal to that, and it tries to go through peristalsis through that, then it becomes a pencil, and then it plops out, and then it continues down distally. So you could, in theory, have a pencil-thin stool. But the reality, though, is that as those little things pencil through, they're going to layer up and make a little log cabin, and it'll form back into normal poop. You won't even know. So that's the debate. More imaging, CT, right? We talked about CT. You will utilize that for cancer screening. And that one's cool. You can see that, the big old arrow sign there. So this is a slow-growing cancer, which is nice, generally. So it's likely it's been there for years before the diagnosis. But again, if they've got more generalized symptoms when they're coming to see you, it's a worse prognosis. So what do? We do routine screening. Right? USPSTF has given us guidelines. And you've heard of A, B, C, D when it comes to USPSTF. And that is what you should be utilizing as a primary care, family medicine, PA going forward. There are multiple guidelines that are out there. Use it at your will, okay? But you'll always be safe if you utilize USPSTF. And you'll find there's some frustrating things when it comes to recommendations between maybe the American College of Obstetrics and Gynecology and USPSTF, or maybe the American Heart Association and USPSTF. And so think about why do they differ? Well, that's a conversation we'll have next semester. But what is it telling us here? There's an A grade for doing colonoscopy or screening, not really I said colonoscopy incorrectly, doing colorectal cancer screening, 50 to 75 years of age. There's a B rating for adults 45 to 49. When I was sitting in your seats here, that B rating didn't exist. This is a newer thing. We're seeing now in the data that colon cancer is present in our population here in America much sooner, in the 45 years of age. So the main takeaway is that we're screening all patients between the ages of 45 and 75 for colorectal cancer. That is the standard. Why do we stop at 75? What's that?
Out of care.
Out of care? I mean, sort of.
Worse surgical outcomes.
Worse surgical outcomes, right?
Because the net benefit is small.
Yeah. We think about 10-year survival rates, 5-year survival rate. If they're already 75, we're gonna get them to live to be 85? Probably not. And this isn't conserving healthcare resources. This is also patient desires and goals. We also know that the more Jerry you are, the worse outcomes you have under anesthesia. You can go under anesthesia at 71 years old for a normal procedure, come back out, and now you have dementia. That's a real thing. So, we're like, you know what? We're not going to do the anesthesia stuff. We're not going to do the propofol nap. If you get cancer, you get cancer, right? That's fine. Have some ravioli. So average risk patients, we have our visualization-based tests, our stool-based tests. Colonoscopy, that is our go-to. And we're doing that at every 10 years. There's asterisks there. Right? Because if a diagnosis is established, or maybe there's some type of polyp that does look dysplastic, that will certainly adjust when the next colonoscopy is. If they have Crohn's disease versus if they have ulcerative colitis, right? But you can think generally, colonoscopy every 10 years. CT colonography every 5 years. Now, that comes with risk too, though. That's a lot of radiation. But they're already 45 or older, so like, who cares, right? It's fine. And then FlexSig, that's every 5 years. You can do every 10 years if you utilize that fecal immunochemical test as well. That's not bad. And we know that a lot of our cancerous lesions within the colon, they appear within that descending colon anyway. So if we're just using the FlexSig and a little bit of blood testing, every 10 years should be just fine. So our stool-based tests I already mentioned, you can just do the fecal immunochemical test all by itself, but you gotta do it every year. Okay, I don't wanna have anesthesia. I don't like this risk of perforation. This isn't for me. We'll just test your poop every year, okay. Sensitivity, not nearly as close as those direct visualization methods, pretty good. And you think about risk stratification for any of these stool-based tests, right? If they have a first-degree relative, they're going to recommend the stool-based. Probably not. You're like, let's do the full thing, and then maybe we can talk about doing the poop test every year. But let's actually go and visualize first, and you can combine. You can make a recipe for a patient there, and you're still evidence-based. The high sensitivity quiet fecal occult blood test annually, and then we have this FIT DNA. Every 1 to 3 years. I've mentioned this a few times about socioeconomic determinants of health. Different insurances pay for different stool-based tests. And so you may be choosing one of these based on their insurance and not the patient's desired. This is weird. That's a weird thing. Like, hey, I would like for you to do the every 3 years thing. They're like, no, we'll get denied. Will not get reimbursed, and that patient will be in the hole for that. Today, colonoscopy, gold standard for screening and definitive diagnosis. And now here's the thing too. When you test your poop, we find something that's a positive test, or we're uncertain if it's positive versus negative, we have to go do direct visualization. We should do colonoscopy, like that's standard of care. You're still gonna have to fight, like, hey, could we just do the CT? No, the colonoscopy is the preferred thing, like, hey, it looks like you probably have colon cancer. Let's go in there and let's go grab it. Let's take it out. So those are the stool-based tests I mentioned, and this is just kind of nice to know stuff, but you might have seen these, again, watching the Super Bowl, and then talking about poop. The hemoccult is one's like coag-based fecal occult blood. The fecal immunochemical test, the IFOPT or FIT, and then the Cologuard. And if I put these things on an exam, they're gonna have the brand name as well, for sure. Okay, so family history is positive. So any first degree relative less than 60 years of age, greater than 2 first degree relatives regardless of age. Now we're talking about adjusting our screening. So we're beginning screening in those patients at age 40 or 10 years younger than the youngest age of the relative that had cancer. If I need to say that again, I will. Hopefully you could read that and it's clear. A takeaway is that I'm gonna have to do something I hate on exams. I'm gonna have to make you do math. And I hate that. You're gonna have to do subtraction. And that's dumb, but it's a learning objective I want to make sure that you are tracking. So a first degree relative, and I described that. There's not gonna be a slide that says what a first degree relative is. I just explained it to you. It's mom, dad, brother, sister, okay? And then what age did they get cancer or get diagnosed? Well, subtract 10 years. How old is the patient? Oh, they're 39. When's their first colonoscopy? 40, okay? Like that's the way it works. Now here, the IBD, these are the guidelines I want you to know for cancer screening, for our inflammatory bout. I kind of glanced over them in the previous lecture. They match, but this is more direct. So colonoscopy with biopsies by 8 years of onset, followed by surveillance every 1 to 2 years. Looking for colorectal cancer. Those other acronyms are those polypoid disorders, and I just ignored it earlier. Okay. CEA. You've heard of CEA. It's a cancer marker. It is not utilized in any capacity for colorectal screening. We utilize this after we already have the diagnosis. There are quite a few labs out there that exist in the same manner. And again, think about as to why. False positives, false negatives. So we already need the establishment of the diagnosis to trust that when this thing is positive, it's truly positive. That's why we don't use it as a screening tool. It can be useful, quite often, prognosis or disease recurrence. And all it's going to do is tell us to go back there and look again. That's all it's going to do. Treatment, they're going to see surgery, they're going to see oncology. Is an oncologist a surgeon? No. They're not. Right? They're internal medicine physicians that then specialize in oncology. Can you be a surgical oncologist? Yes, again, 4 years of medical school, 5 years of general surgery, and then 3, 4, 5, or 6 years of oncology. And then there are surgical oncologists. It's a lot of training. Just trying to give you context of what the 2.5 years that we do here versus our physician colleagues, especially surgeons. We can do surgical resection, full or partial colectomy, chemotherapy, radiotherapy, all the things. We got all of them. There's a lot. Current goes through everyone, just like shut up, okay? It's patient-based. Prognosis-wise, stage 1, stage 2, stage 3, this is a good to know. Know that cancer staging is its own rabbit hole, and it doesn't tell you a whole lot. If you just hear the TMF staging of someone's cancer, it generally doesn't tell you a whole lot. They're telling you here, sure, there's a prognosis associated with the staging. I would say that this is also more nuanced. This is a nice to know. And the worse the stage, the worse the prognosis. That's kind of consistent though. But comparing stage 3, stage 2, how many lymph nodes, it gets pretty nuanced. So our final takeaway with colorectal cancer is you're educating your patients on how serious this cancer is. Remember, I told you it's the second leading cause of cancer-related death in this country. And we're seeing it pop up earlier and earlier. And we know the gold standard is direct visualization with colonoscopy. Is there a risk for anesthesia? Is there a risk of perforation? Is there a risk for infection? Those all exist. Sure, fine. But if we find that cancer earlier, we can treat you earlier, and then you're going to be just fine. Right? So that's the conversation you have to have with them. You give them the other options. What would you like to do? And then tell them also insurance-wise what their insurance prefers them to do. And again, have those tough conversations. What are your questions? All right, that's all I got.
Thank you, sir.